friends, this is Dr. Ganga. Today we'll be learning acute interstitial nephritis. So coming to the definition, what is acute interstitial nephritis? So the word itself says it is acute, that is it happens suddenly as a response to something. It is often reversible, that is with correct recognition and treatment we can reverse the disease, and there is inflammation of the interstitium. So it happens acutely. Inflammation of the kidney is seen, that is nephritis. Which part of the kidney is inflamed? It is interstitium, and it is often reversible. Now coming to the pathogenesis of this condition. This inflammation is a response to an antigen. What sort of a response? It's a hypersensitivity reaction, that is allergic reaction or a hypersensitivity reaction to an antigen. So what is the evidence that we have that it is hypersensitivity? It occurs only in few people. Like we know, allergies to a substance does not occur in the same fashion in all people. It occurs in few people, it doesn't occur in few people. So the proof that acute interstitial nephritis occurs as a hypersensitivity is that it occurs only in few people in response to a particular agent. Second is, it is not dose dependent. Again, this is a characteristic of anaphylaxis or allergy or hypersensitivity, that is even a minimal dose can elicit this allergic response. Extrarenal manifestations occur. That means this allergy is not just limited to the kidney, it can happen elsewhere. We learn further that these allergens can cause rashes, it can also cause arthritis, other features of hypersensitivity reaction. It recurs after re-exposure to same drug. This drug is re-exposed, it will elicit the same response causing allergy and causing inflammation. And there is formation of granulomas. When there is chronic inflammation, granulomas occur in the kidney. There is absence of neutrophils and infective agent from the renal parenchyma. One of the close differentials were whether this is infection. So when neutrophils are absent from the kidney biopsy, and they could not isolate any infective material from the parenchyma. So these two things proved that this entity happens because of allergy or hypersensitivity and not because of any other event. So by knowing all these things, one thing is we come to a conclusion that it is a hypersensitivity reaction. Second thing is, once we detect that the person is allergic to this particular drug or hypersensitive to this particular drug causing interstitial nephritis, we should avoid re-exposure of the drug. Now continuing with the pathogenesis. For every hypersensitivity reaction, we know that there should be an antigenic stimuli and response of the body. So which are the antigens that are seen in acute interstitial nephritis? First is tubular basement membrane. We have the tubules. This is the tubular epithelium. So this tubular basement membrane can itself form an antigen. Second is secreted proteins. There can be secreted proteins from the tubule like Tom Horsfall protein, we know, which is secreted from the loop of Henle. It can be a hypersensitivity reaction to the secreted protein. Third concept is where there can be non-renal proteins. So the two of these were directly present in the kidney, that is the tubular basement membrane and the secreted Tom Horsfall protein. There can be non-renal proteins also, which is produced by drugs or infection that can precipitate allergy in the kidney or cause acute interstitial nephritis. So what are the mechanisms by which these non-renal proteins will cause it? One is planted antigen. That is, if this is the tubule, the antigen gets planted into the kidney. This can be any drug or this can be any infection or any bacilli virus for that matter. So it can get deposited in the kidney causing planted antigen. Second is it can form a hapten. Hapten we know is a support for already present incomplete antigen to form a complete antigen. So if already some antigen is there and this goes and acts as an hapten and makes the kidney vulnerable for interstitial nephritis. Third is it mimics a renal antigen. So if this antigen is already mimicking some component of the kidney, some antigen of the kidney, then also it can elicit immune response. Fourth is precipitation of immune complex. That is, this drug causes antigen. Antibody is present in the systemic circulation against this antigen, that is the drug. this immune complex goes and gets deposited in the kidney. So in this situation also we see that acute interstitial nephritis is occurring. Now coming to the immunopathogenesis, what happens once the antigens are formed? Now it is time for the body to respond. So cell-mediated immunity is the most important modality, that is interstitial nephritis. When biopsy was done, majority cells that were seen were lymphocytes. So they noticed that cell-mediated immunity is playing the most important part. But also, like I told in the previous slide, that we noticed that this tubular basement membrane formed an antigen for which anti-TBM antibodies were formed. So they also found that antibody mediated immunity is also playing an important role like cell mediated immunity. So once cell mediated or antibody mediated immunity goes and binds to the kidney, antibodies or the lymphocytes, an inflammatory reaction is elicited. This activates the complement. Once the complement is activated, there is release of inflammatory mediators, which are interleukins, cytokines. This further brings in or attracts lot of lymphocytes, which goes and deposits in the interstitium and causes interstitial nephritis. And if this is not treated, in the long term, it can lead to IFTA and CKD. What is IFTA? IFTA is interstitial fibrosis and tubular atrophy. See, the kidney is basically 4 major compartments. One is glomerulus, other one is tubule, third one is interstitium, 4 is vascular. This disease basically affects the tubule and the interstitium compartment. So, tubule, the chronic manifestation of tubule involvement is tubular atrophy, and the chronic manifestation of interstitial involvement is interstitial fibrosis. From now on, you will be coming across this term commonly, IFTA commonly. So, that is why I have explained this. IFTA means interstitial fibrosis and tubular atrophy, which are chronic manifestations of inflammation in the interstitium and in the tubule. Now, this diagram shows us the same mechanism which I have told you. First, I would want you to concentrate on this part of the diagram. So, here there is a processed antigen. Okay, the processed antigen is being taken up by the antigen presenting cell, which is a macrophage here. It is representing it to the T lymphocyte. This is how any form of immunity is established in the body. Once an antigen comes, it is processed by the antigen presenting cell and then it is exposed to the T lymphocyte. So, T lymphocyte gets exposed. Once the T helper cell gets stimulated, it activates TH1 and TH2. The TH1, this is TH1. What it does, it activates the natural killer cell. It activates the cytotoxic T lymphocytes, the macrophages and the neutrophils. Once the cytotoxic T lymphocytes are activated, it goes to the tubule. The same antigen which was here, you can notice that the same antigen is here. Now, it is going to destroy this tubule. It is going to, in fact, attract a lot more of neutrophils, monocytes, and it is going to come to this part of the tubule and it is going to destroy that part. So, there will be inflammation, lot of inflammation in the interstitium, there will be lot of inflammation in the tubule. Okay, so this is the cell mediated part. Now, coming to the antibody mediated part, similarly, you can see the T lymphocyte. T lymphocyte is going and activating the B lymphocytes. What is the B lymphocytes doing? B lymphocytes is again forming plasma cell. It is secreting antibody. This antigen-antibody complexes are getting formed. Antigen-antibody complexes here stimulate complement activation. Once complement is activated, it again goes and brings in a lot of neutrophils and monocytes into the interstitium. So, this is how it is a vicious loop where once the antigen antibody is exposed to the T lymphocyte goes and further brings in a lot of other lymphocytes, neutrophils, macrophages, NK cells, and T lymphocytes also stimulates the B cells to produce the antigen antibody, the complex of which will cause complement activation. Once the complement activation occurs, there is a lot of inflammation and injury to the kidney. So we learnt about the antigen antibody complex formation and how cell mediated immunity, that is lymphocytes, is important in this system. Now coming to the epidemiology, how common is this? Out of all biopsies that was done for acute kidney injury, only 2 to 3% of renal biopsy showed feature of acute interstitial nephritis. Earlier times when antibiotics use was not very common, scarlet fever and diphtheria were the causes for acute interstitial nephritis. But at present, drugs are the most common cause of AIN, 70 to 90%. So, it is an important question. It's an MCQ. You'll have to remember that in the current era, drugs, which is very rampant, drugs in the sense, I'm not talking about IV abuse drugs. I'm talking about medications, which we commonly use. That is what is causing acute interstitial nephritis. In fact, when I tell you which are the medications, you might be shocked that the common medications which is being used over the counter are the culprits for acute interstitial nephritis. So this is responsible for 70 to 90% of acute interstitial nephritis. Now drug-induced AIN, let's come to each entity. First, among drugs, the most common is antibiotics. That is, this is also the most commonly overprescribed drug. So it is also most common in causing acute interstitial nephritis. So earlier methicillin was commonly used, and methicillin was very much prone to cause acute interstitial nephritis. But once methicillin use has subsided, that has also subsided. But there are other drugs which are beta-lactams, that is penicillin group of drug, fluoroquinolone, sulfonamide and rifampicin. Now, see, it is very much essential to remember these drug classes. In this, we know that these are the drugs that have been used rampantly, even for a upper respiratory tract infection for that matter. The most common drugs that are given are beta-lactams and fluoroquinolones. And otherwise also trimethoprim sulfamethoxazole is used for coverage of many infections. And rifampicin is the only drug which is not given unnecessarily but as a part of ATT. So, seeing that if beta-lactams, fluoroquinolones and sulfonamides are the drugs that can cause AIN, then you must understand that AIN is also pretty rampant because of the overuse of these drugs. Second is NSAIDs. This is the second group, and the most common is phenoprofen, which is causing that. Third is proton pump inhibitors. This is another class of drug that is being used widely by whole population, with prescription, without prescription. Even as doctors, even as patients, the most over abused drug is PPI. So, our very commonly prescribed pantoprazole and rabeprazole are culprits in causing acute interstitial nephritis. So, this is one thing we have to be very careful about. So, the three major classes are antibiotics, NSAIDs and proton pump inhibitors. Okay. Now, what are the clinical features of acute interstitial nephritis drug-induced? Now, renal manifestation. How will the patient come to us? Patient will come to us with unexplained AKI. That is, see, generally there are two systems. Like I told you, glomerular system is there and interstitial system is there. Now, glomerular system, that is glomeruli which involves the afferent arteriole, the efferent arteriole and the Bowman space. When this is involved, the GFR reduces, the filtration reduces and the urine output reduces. But when tubule and the interstitium is involved, what happens is the urine output is generally maintained. This is a major difference that you have to remember. In glomerular diseases, patient generally presents with oliguria. So, once the urine output reduces, what happens? Pedal edema, that is swelling of legs, will come and also blood pressure will increase. But in interstitial diseases where only tubule is affected, remember that glomerular is functioning normally. So, what will happen? All the blood will come and it will get filtered. It will get filtered and it's just that tubule is not able to reabsorb. So, what will happen? The whole urine is getting passed through the tubule and it will come out. So patient is never going to complain of oliguria. There are only going to be other symptoms. I'm not telling you oliguria is not possible. I'm just telling it is very, very less percentage. Okay, it's less common when compared to glomerular disease. So if there is no oliguria, then what else will be there? Edema also will not be there. Okay, so these two things you have to remember. There is no oliguria, there is no edema in symptoms. Okay. Second thing is, patient will not also show hypertension. Why? Because the tubule is not functioning. There might not be much sodium reabsorption, and also patient is losing good amount of urine. So there is no volume expansion also. These are the two major things that causes hypertension. So those two things are not there. Hence blood pressure can be completely normal in these patients. So we might find it shocking that patients, they come to us and they ask that I have normal urine output and I have no swelling of legs. Then still why are you telling I have kidney disease? Then this is the explanation, this is the concept that we have to make the patient understand that even with normal urine output, even without swelling of legs, even without edema, even with normal blood pressure, renal disease can exist. Okay. So this was just a general concept. Now coming back to this drug-induced acute interstitial nephritis, onset can be over a few days to few weeks. Only exception to this, that is few days to few weeks it generally takes. Only two classes of drugs takes months to present as acute interstitial nephritis, that is NSAIDs and immune checkpoint inhibitors. These both can happen generally over months. And what are the symptoms that they are going to present with? There is going to be flank pain. Let me explain why this flank pain. Generally, kidney is there and then it has the glomerulus, it has the interstitium. Okay. So what is happening? There is lot of inflammation in this interstitium. This inflammation means that lot of lymphocytes are coming in, lot of extra fluid also is going to be there, causing interstitial edema. Basically like edema in any part of the body, interstitium also becomes edematous. This leads to swelling of the kidney. Once the kidney swells, what happens? There is going to be stretching of the capsule which leads to flank pain. Okay. So patient will not have edema, patient will have non-oliguria. Then BP will be normal. Like I explained, the volume will be normal, the sodium will be normal. Because of this, BP also will be normal. So imagine patient goes on taking some drug like PPI or antibiotic. Patient takes it for few weeks and the only symptom patient has is flank pain. Maybe patient will have some features of uremia like some amount of vomiting or generalized discomfort can be there. But none of this is suggestive of renal disease. So this patient will be primarily not coming to you as a nephrologist. Patient might meet a physician. And once the labs are done only, it will be known that this is kidney disease and the patient will be sent to you. Okay, so this is a disease that presents in a non-renal fashion. We can tell that typical renal fashion of reduced urine output and edema and high blood pressure is not going to be there. Now coming to the labs. In labs, two important things. First, what we see the creatinine. Second, what we see, urine routine. So creatinine, of course, there will be sudden increase. For example, think last month when the doctor started the patient on that antibiotic, a baseline investigation was done and RFT was normal. This month, the patient is coming back telling, I have severe flank pain, I am feeling uneasy, I am not able to eat. But he finds that there are no other symptoms, BP is normal, he sends investigation. Suddenly he notices that the creatinine is 5 or 6. That is when it should ring a bell that it is acute interstitial nephritis. Similarly, in urine routine, what are the entities that we have to see? Generally, we see for any presence of cells, we see for presence of cast, we see for presence of protein. So among cells, there can be RBC, there can be WBC. Okay. So RBC, it can be mostly it will be microhematuria, that is in the urine routine report, you will find some 3 to 4 RBCs. WBCs also can occur. You might find some 10 to 15 WBCs or 20 WBCs. So what can happen? as soon as we see WBC, we see deranged RFT, we might think it is pyelonephritis. But remember, these patients, only few patients have fever. Majority patients of acute interstitial nephritis do not have fever. As it is, we can send culture for the diagnosis of urinary tract infection. But it becomes a close differential for us investigation wise. So, patient will not have any burning micturition or any classic features of UTI. So, but WBCs can be there. So, this is one of the differential diagnosis of sterile pyuria. Next is coming to cast. Sometimes WBC cast can be there. WBC cast is nothing but clustered WBC. When is a cast formed? When a lot of cells combine along with the Tom Horsfall protein. I told Tom Horsfall protein is secreted in the tubule. So, a lot of cells combine with it and it forms the shape of the tubule. So, this is cast. Okay. So, this cast, when lot of WBCs are coming, there's lot of inflammation in the kidney. The lot of neutrophils are coming, monocytes are coming, eosinophils are coming. These are getting filtered into the tubules. Once these are getting filtered into the tubules, it binds to the secreted protein, that is the Tom Horsfall protein. Once it binds to the secreted protein, it forms a cast. Cast is nothing but clumping of this Tom Horsfall protein with the cells. Okay, so this cast can be seen. But RBC cast will not be seen. This is a very, very important point. First thing, where is RBC cast seen? RBC casts are seen only in glomerular diseases. In interstitial diseases, generally RBCs will not come much into the interstitium, into the tubule. It is very, very rare. Like I told, you can find microhematuria mostly. So, RBC cast will not be seen. So, in the exam, if a clinical scenario, like I told, a clinical scenario will be put like a patient takes this particular drug for 1 month. After that, he presents with flank pain, but normal urine output, normal blood pressure, no edema, and investigations are showing creatinine of 5. Along with that, urine routine is showing WBC cast, hematuria, pyuria, but no RBC cast. So, that time it should click that the diagnosis you are dealing with is acute interstitial nephritis. Okay, so this is about the cast. Third is protein. Mild proteinuria can be there. We know that the tubule secretes around 1 to 2 gram of protein. So, when there is the tubular function is defective, the reabsorption does not occur and this protein is excreted. In the basics of glomerular disease, you would have learned that there are glomerular proteinuria and tubular proteinuria. Glomerular proteinuria generally is in the nephrotic range or in the subnephrotic range. But tubular proteinuria is generally around 1 to 2 gram, okay, or lesser. So, that proteinuria can be seen. So, these are the urine routine findings. So, you will see for cells, you will see for cast, you will see for proteinuria. Mild proteinuria can be there, few RBCs can be there, WBCs can be there, WBC cast will be there, but there is no RBC cast. Then after that, you will proceed with USG. USG will show normal or increased normal or enlarged kidney. So, I told that what happens here, there is inflammation in the interstitium. So, anywhere inflammation occurs, like in a wound, swelling occurs. So, kidney swells up. So, there can be normal size kidney or enlarged kidney with increased cortical echogenicity. That is, there is a lot of fluid accumulation in the cortex. Generally, when USG is done, medulla appears bright and echogenic. Cortex is not that echogenic. But here, because of the edema, even the cortex starts appearing echogenic, and hence what happens, there is increased cortical echogenicity. So, I hope clinical features of acute interstitial nephritis, especially drug induced, are clear. Now, clinical features are not just present in the kidney. It is present extrarenally also. So, extrarenal manifestations are mainly fever, maculopapular rash and arthralgia. So, 3 main features occurs. First is fever. So, if fever also occurs, then our diagnosis of UTI also will come into a picture. But luckily with urine culture, we can rule out urinary tract infection and we can point upon interstitial nephritis. Second is maculopapular rash. So this picture you are seeing, this is a patient with drug-induced AIN who is having a maculopapular rash that is present in the legs. Third is arthralgia. Like any hypersensitivity reaction, joint pain is commonly seen in patients with acute interstitial nephritis. So this is a disease because of hypersensitivity has both renal and extrarenal. Okay. So arthralgia is also one of the common manifestation. Now, when there is extrarenal manifestation, generally we find eosinophilia in the blood. Okay, if there are no extrarenal manifestations, we might not find, but if there are extrarenal manifestations like patient has fever or rash, then blood might show eosinophilia like any other hypersensitivity reaction. Now, patient having each of these symptoms, that is, there might be renal failure, along with that patient can have fever or patient can have rash or patient can have arthralgia. So, the chance of that is 50%, around 50%, okay. But to have all these symptoms together, it is only less than 10%. So, we cannot rely on patient having fever, rash, arthritis and kidney failure to make a diagnosis of AIN. So, AIN is one of the most difficult diagnosis to make because of the multitude of causes that can happen to cause it, and also because of the difficulty in diagnosing it. Now, here is the picture. This chart will show what is the frequency of manifestation that we are seeing in patients with AIN. Okay, so till here it is renal manifestation. So, first in renal manifestation, like what I told you, blood investigation we see, that is creatinine. After that, what we see? Urine routine. Then we need the symptoms related to kidney disease. So, let's see these three things. In the kidney, renal failure, that is elevated serum creatinine, that is seen in 90% of the patients. Okay. So, serum creat elevation, 90% of our patients will show, there is no problem. Next, the most common things that is occurring is mild proteinuria and pyuria, that is proteinuria of 1 to 2 gram and also pus in the urine. Again, please remember this is sterile pyuria. Okay. So, this is the next common manifestation that is seen in around 50 to 55% of patients. The next common manifestation is hematuria, which is microscopic. That is, there will be presence of few RBCs in urine, like I told. That is seen in 50 to 55% of patients. Macroscopic hematuria, that is visible presence of blood in urine, is seen only in 20% of patients, and oliguria is seen in 30% of patients. So, among the renal manifestation, just remember most common is increase in serum creatinine. 90% of patients come with that. Apart from that, when you take the urine routine report, you can find some WBCs, you can find 1 to 2 grams of protein. This is seen in more than 50% of patients. Few RBCs also, 2 to 3 RBCs can be seen in more than 50% of patients. Presence of reduced urine or presence of frank hematuria is seen in less than 30% of patients. Okay, so these are the renal features. Now, coming to the extrarenal features, it's seen in around 40 to 50% of patients. Extrarenal features we discussed as fever, maculopapular rash and also arthralgia. And eosinophilia, like we said, when extrarenal symptoms come, eosinophilia comes. So, eosinophilia is also again seen in 30 to 40% of patients only. So, it is seen in lesser number of patients. See, in this whole chart, what I am trying to insist is, the commoner features are only creatinine will elevate, patient will present with some proteinuria, patient will present with some WBCs, WBC cast and maybe few RBCs. Rest all manifestations are uncommon, it is only around 30 or 40%. So, we cannot depend on those manifestations to make the diagnosis of AIN. Now, coming to specific drugs, we were dealing broadly about drug-induced AIN, now coming to specific drug. With methicillin, which was earlier used, we noticed that there are well-preserved renal function and only less than 50% of these patients have renal failure. Generally, they present with extrarenal manifestation, which is fever, arthralgia, and also maculopapular rash. And also they might have abnormal urine analysis. Like by now it is clear what is the abnormal urine analysis, like proteinuria and presence of WBCs. So the peculiarity of methicillin induced AIN, if asked in exam, is extrarenal manifestations are more common. Renal manifestations are not very common. Only less than 50% of patients have renal failure. Now coming to rifampicin induced AKI. Now, before telling about this, I'll just tell about a patient who came to us. This patient was a 30-year-old male, Mr. X. He had come to us with history of sudden onset reduction in urine output. Okay, sudden onset reduction in urine output, and when we did investigations, his urea was 230, around 230, creatinine was around 12. And then when we saw the urine routine, he had only 1 gram proteinuria. He had few WBCs and few WBC cast. And even RBCs were a few, only 2 to 3. So, we were confused that whether interstitial disease should not cause sudden reduction in urine output. But his investigations is more or less suggestive of interstitial disease, and so what could be the cause? Then we started digging into the history again and again. So this patient had tuberculosis 15 years ago, and he had completed the course of anti-tubercular treatment. And now he had again had pulmonary TB recurrence, for which he was started on ATT, which included rifampicin. And hence it struck to us that it could be rifampicin induced AKI. We did his renal biopsy. We could prove it is acute interstitial nephritis. We stopped rifampicin treatment, and because later when we come to the treatment, I will tell you how steroids is important and in which condition we can give. So, because it is infection, we gave him a low dose of steroid, and patient became completely alright. His renal functions completely recovered. From 12 creatinine to complete recovery was seen because of early detection. That is important. So, why I told about this drug, rifampicin specifically, is there are few things that are very characteristic of rifampicin induced AKI. First is, there should be history of prior exposure. Our patient had history of prior exposure, that is 15 years ago he had taken treatment for TB. So, rifampicin in his body that time had induced some stimulus, and some amount of antibody response also would have been formed that time. It should happen on re-administration. Obviously, when there is prior exposure, only if it is re-administered, then this situation will occur. Or many months of intermittent administration, that is, you are administering it intermittently. This is also another characteristic that is seen with rifampicin induced AKI. So, majorly it is seen with re-administration or many months of intermittent administration. Now, there can be extrarenal symptoms like fever, GI symptoms and myalgia. Laboratory investigations will show thrombocytopenia, hemolysis, hepatitis and anti-rifampin antibodies. Now, we know that hepatitis can occur with ATT, that might be seen. There can be antibodies which are formed against the RBCs and also the platelets. So, there can be hemolysis, there can also be thrombocytopenia. And on investigation, we can discover anti-rifampin antibodies. Now, once renal biopsy is done, we see the same thing that we see, that there is tubular injury along with interstitial infiltrates. There is a special type in which even continuous administration for many months can cause, but this is very rare. Don't have to worry about it. The common is this. So, you can also be given a clinical scenario in exam where a patient previously took ATT, now again he was re-exposed to ATT and there is sudden increase in creatinine. What could be the cause? Okay. Another feature about this rifampicin induced AKI, like I mentioned, is that patient can present with reduced urine output also. Around 15 to 20% of patients can have reduced urine output also, but again, for you to know, it is not very common to have low urine output in acute interstitial nephritis. Now, the other drugs are, this I have just included because if any fact-based questions can be asked, like phenandione along with AIN causes fatal hepatitis. So, the drug that causes fatal hepatitis plus acute interstitial nephritis is phenandione. Okay, similarly, allopurinol, we know that it causes Stevens-Johnson syndrome, it causes liver dysfunction, especially in HLA-B58 genotype. It can also cause acute interstitial nephritis. Now, coming to an important drug, which is NSAID. See, NSAID, one exception, there are multiple exceptions. One of the most important exception is the proteinuria is going to be massive. It presents as nephrotic syndrome in 3/4 of the cases. Okay, I told you that tubular proteinuria is generally 1 to 2 gram. Only glomerular involvement happens, then only we will find severe proteinuria. But this is an exception where patient can have severe proteinuria, nephrotic range proteinuria. It is generally seen in people more than 50 years. It could be coincidental because we see only elderly people abusing NSAIDs, so might be coincidental. That is why it is seen mostly in elderly. Any NSAID can cause, including COX-2 inhibitor. There is nothing like only COX-1 inhibitor will cause. Even COX-2 inhibitor can cause. And like discussed earlier, most common is phenoprofen, and it occurs after few months. So this is also an exception. We learned that all drugs causing acute interstitial nephritis causes within few days to few weeks, except 2 drugs. One was NSAIDs, second was immune checkpoint inhibitor. So this is first exception. This is the second exception, that it occurs with nephrotic syndrome. Okay. So in some cases it can happen to few days, 2 years later also, but generally the dictum is it takes months. Okay. So presentation is, because there is heavy proteinuria, patient will have edema. Extra renal features are not very common. Now I would like you to concentrate on this chart again here. Edema is seen in 80% of the patients. Okay, so edema is a more common manifestation. So we might get easily confused with glomerular disease. And even hypertension is seen in 20%. But in glomerular disease, hypertension can be seen in larger number, 80 or 90%. So that is one thing that is going to help us. Generally in nephrotic syndrome, hypertension is less common. It is not seen. So like that only, here also hypertension is less common. Apart from this, there can be eosinophilia. There can be pyuria, that is, like I told, WBCs can come in the urine. There can be hematuria. Macroscopic, all these form around 40%. Rest extrarenal symptoms and macroscopic hematuria are very uncommon. So the takeaway point from this slide is there are 2 major exceptions. One is it can present with nephrotic syndrome. Second is it takes few months to occur. So these 2 things has to be remembered. Then as a logical sequence, you can remember that if nephrotic syndrome is occurring, then edema can occur. Okay. Now, this is an important MCQ. What all can NSAID do to the kidney? NSAID intake. First is hemodynamically mediated AKI. So, this hemodynamically mediated AKI occurs because this is the afferent arteriole, this is the glomerulus thing, this is the glomerular capillaries, this is the efferent arteriole. Okay. Now, for this afferent arteriole to dilate, prostaglandins are required. These prostaglandins are normally produced in the kidney, and prostaglandin is required for the afferent arteriolar dilatation. We know that is COX, that is cyclooxygenase. It is what required for the production of prostaglandin. So once COX reduces, or COX is inhibited, prostaglandin production is reduced, because of which afferent arteriolar vasoconstriction will occur. Okay, vasoconstriction will occur. This will lead to reduced GFR and hemodynamically mediated AKI. So this is the mechanism. Second is papillary necrosis. In the next slide, I'll be dealing with why papillary necrosis is occurring. It is because of lot of free radical accumulation in the papillae of the kidney. NSAID induced membranous nephropathy. Here in the glomerulus, it can cause membranous nephropathy. In the interstitium, it can cause acute interstitial nephritis. Okay, finally, then when the tubule goes, it can cause papillary necrosis. This is the collecting ducts which goes and drain into the papillae, renal papillae. So, 4 important manifestations, that is hemodynamically mediated AKI, which is the first manifestation because of afferent arteriolar vasoconstriction. Second is membranous nephropathy, which is the glomerular involvement. Third is in the interstitium, it can cause acute interstitial nephritis. Fourth is in the papillae, it can cause papillary necrosis. Now, what happens is, there are inflammatory infiltrates in the interstitium, which is the hallmark of this disease. Okay. Now, it can be patchy. This is very important because you are doing renal biopsy. Assume here there is interstitial nephritis, here there is interstitial nephritis. You are going like this and you are getting the tissue. This is the renal tissue that you are getting. So, if it is only here, your diagnosis here can be hampered. You can get a normal biopsy. So, taking multiple course would be relevant in this situation where acute interstitial nephritis is there. And that also it is present in the deep cortex and in the medulla. These are the parts generally while biopsying we do not biopsy medulla because it is vascular and it can lead to bleeding. So, it is generally present in the deep cortex and medulla. So, this I am telling because you must understand it is very easy to miss a diagnosis of acute interstitial nephritis. Now, once you see the pathology, you see a lot of T cells, monocytes, macrophages, plasma cells, eosinophils. We discussed all this in the pathogenesis. There can be tubulitis, that is, in the tubule, like we discussed, the lymphocytes can accumulate. So, that itself is called tubulitis. And when a lot of these inflammatory cells accumulate, it can form granuloma, which can be sparse. It is non-necrotic and there can be few giant cells. The granulomas that are seen in the kidney are non-necrotic granulomas. Okay. So, just few words about granulomas. Granulomas itself can form something called granulomatous interstitial nephritis, that is a specific type. Okay. So, in this, the drugs can cause general autoimmune diseases, whichever causes granuloma elsewhere in the body can cause, and also infections can cause. So, this is like common, whatever is causing elsewhere in the body will cause. So, sarcoidosis, Sjogren's, Wegener's granulomatosis. These three are the autoimmune diseases which can cause granulomatous interstitial nephritis. So, we know that these are the diseases that can cause granulomas elsewhere also. In infection, TB, Salmonella, EBV and Toxoplasma. See, TB and Salmonella is important to remember. It is okay, EBV and Toxoplasma are also there, but they are rare causes. These are common infections and they themselves can produce granulomatous interstitial nephritis. Then, I would like you to concentrate on drugs which are sulfonamides, PPI and narcotics. Okay. So, how an easy way or a tactic that I use to remember this is, granuloma is, I put it as granny. My granny has NPS. I am sure you all would have heard about National Pension Scheme, which can be taken only once you are old. I use this National Pension Scheme to tell that it is generally seen in elderly, which is granny. So, granny denotes granulomatous interstitial nephritis. Okay. So, N is for narcotics, P is for PPI, S is for sulfonamides. So, these three major classes of drugs can be remembered. This can be asked as an MCQ. Drugs causing granulomatous interstitial nephritis. So, you can remember granuloma means NPS, okay, which is narcotics, PPIs and sulfonamides. Next is heroin abuse and jejuno-ileal bypass, which are uncommon causes. See, it is simple. The list seems elaborate, but one is immunological diseases, second is infection, third is drugs. So, in drugs, you can remember NPS, that is narcotics, PPI and sulfonamides. So, these are the important cause of granulomatous interstitial nephritis. So, this picture here you can see these are the formation of granulomas. Here granulomas are forming. Okay, see, these are showing eosinophils. I hope you can see the H&E staining. These are the eosinophils that are present. Okay, and these are the granulomas that are getting formed. What I'm circling are the granulomas that are getting formed. Now, continuing with the pathology. So, we told that there will be a lot of inflammatory cells that are present in the interstitium. So, what will happen? There will be interstitial edema. Like we discussed, this will cause nephromegaly. And severe inflammation can disrupt the tubular membrane. Here you can see all these are the inflammatory cells. If you compare any normal renal histology, I would tell you to just see a normal renal histology. Google just a normal renal histology and compare the cells of that with this. This is numerous cells that are present in the interstitium. So, this is what is seen, and there will be severe inflammation. Vascular and glomerular architecture are completely normal. So, your blood vessels and glomeruli are generally not involved. Now, exception is if NSAID causes membranous nephropathy along, then there can be glomerular involvement. Then when we see the immunofluorescence, sometimes there can be granular staining of the immunoglobulin on the tubular basement membrane. Okay, so this is mostly seen in drug-induced AIN. So, tubular basement membrane, we discussed that there will be antigen, so there will be antibody to them. So, there will be granular staining of this immunoglobulin in the tubular basement membrane. So, this is the pathology. Now, coming to diagnosis. How to diagnose this condition? Most accurate is renal biopsy. We discussed symptoms does not help us, signs does not help us, even investigation wise urine routine can lead us elsewhere. So, the most useful, most accurate is renal biopsy. Okay. The other helpful things are eosinophiliuria and gallium scanning. Now, what is eosinophiliuria? Eosinophiliuria is if there is more than 1% of the urinary WBC is eosinophils, then it is called eosinophiliuria. Okay. It has poor sensitivity and low predictive value, and this test should be abandoned. So, basically this test I'll be explaining later. In the next slide you will see that there are multiple causes of eosinophiliuria. So, just because eosinophiliuria is there with elevated creatinine, I cannot tell, and it is not that all cases of acute interstitial nephritis will have eosinophiliuria also. So, it has poor sensitivity and poor predictive value. And final diagnosis is by biopsy only and clinical response to withdrawal of the drug. So, once we withdraw the drug, if patient is becoming okay and biopsy is showing multiple inflammatory cells, then that is the only way to confirm this diagnosis. Now, in this picture, I am just trying to stress the point that I told you about eosinophiliuria. Here, you can see this is drug-induced AIN, these two. Okay. So, drug-induced AIN, this is the group, this is drug-induced AIN. In that, this much section of patients have eosinophiliuria, this many section do not have. Now, this is non-drug-induced AIN with eosinophiliuria. In non-drug induced, this many section only have eosinophiliuria. Okay, that is very small. Majority section of non-drug induced are without eosinophiliuria. ATN. In ATN also, this much section is associated with eosinophiliuria and the other section is not associated with eosinophiliuria. Okay. Now, other causes of eosinophiliuria. Now, it is not just present in acute interstitial nephritis. We saw that in acute interstitial nephritis it is there. It is also present in acute tubular necrosis, crescentic GN. Crescentic GN, lot of inflammatory cells are poured into the kidney in crescentic GN. So, in crescentic or proliferative GN, it can be there. Atheroembolic renal disease. What happens in atheroembolic renal disease is there is formation of atheroma in the renal vessel. Similarly, there will be formation of atheroma elsewhere in the body. This will elicit a systemic inflammatory response where a lot of eosinophils are present. So, this eosinophil will also come from the blood into the kidney and from the kidney into the tubule. So, all this eosinophil is lost in the urine leading to eosinophiliuria. So, atheroembolic renal disease is a cause. Apart from this, urinary tract infection, any inflammation of the bladder where a lot of inflammatory cells like neutrophils, eosinophils are brought in. Urinary schistosomiasis, parasitic infection that can cause eosinophiliuria, and pre-renal AKI. So, among these 7 causes, see, this can be asked as an MCQ. Among these 7 causes, drug-induced AIN, ATN, crescentic GN and atherosclerotic renal disease are important causes. Meanwhile, it's easy to remember that UTI and schistosomiasis itself will have eosinophils. So, these 4 causes you should try to remember. Another point is the stain that is used to see eosinophils in urine is Hansel stain. This can also be asked as a factual question. Hansel stain is what is used to see for eosinophils in the urine. Now, along with kidney biopsy and eosinophils, I also told about gallium renal scanning. So, it is based basically on the gallium uptake in the kidney. If uptake is there, it will be seen. So, this is seen within 48 hours of the drug causing injury or the whatever it is, infection causing injury. Within 48 hours, this AN can be diagnosed. But it also occurs in pyelonephritis, in cancer and in glomerular disease. Basically, these are conditions where there is increased inflammation. So, when any increased inflammation will increase the uptake and also cause positive gallium renal scanning. So, in pyelonephritis, in cancer and also in glomerular disease, we will see increased uptake and it can be false positive. Now, can we do anything to identify the causative drug? One is lymphocyte stimulation test. That is, we take the patient's blood, we expose the blood to the given drug. If there is increased proliferation of lymphocyte, that is high proliferation index, then that is a test that can be used. Circulating anti-drug antibody is practical only in terms of rifampicin, not any other drug. Only anti-rifampin antibody is available. So, how this is important is they can ask that lymphocyte stimulation test for the diagnosis of renal failure is helpful in which of the following conditions. So, your answer is going to be acute interstitial nephritis. Now, what are the prognostic factors? See, prognostic factor is dependent on 2 important things. First one is what is the duration of AKI, that is patient has AKI, of course because symptoms are not much, patient comes to us 3 months later, then the prognosis is going to be very poor. It is about identifying fast and treating fast. Second thing is when we do biopsy, if we are finding IFTA, that is interstitial fibrosis, tubular atrophy, there is rich infiltrates of neutrophil or macrophage and granuloma. These 3 are the features in pathology that will be suggestive of poor prognosis. Another important thing is severity of AKI has no predictive value. If you remember the case scenario that I told, where patient who took rifampicin presented to us within 1 week with creatinine of 12, but once we withdrew the drug and treated him with steroid, there was 100% recovery. So, it doesn't mean that if creatinine is 12 and patient requires dialysis, there will be no recovery. That is not seen in AIN. Okay. It is not based on severity, but it is based on duration. If we had sat with the 12 creatinine for 3 months, then we could not have been able to salvage the kidney. Okay. Now, it is seen that in 40 to 50% of patients, serum creatinine does not reach baseline. That is, in around half of the patient, creatinine will be above the baseline only, it will not normalize. So, the treatment of this condition is to withdraw whatever is the inciting agent. That is the first step. Identify what is the cause and remove it. And second thing is steroids can be given. Now, coming to steroids, see steroids generally in infection-induced AIN, it is difficult to give. In drug-induced AIN, we can give. General duration of treatment is 4 to 6 weeks, after which it has to be stopped. After 6 weeks, if it is not working, if patient's creatinine is not improving, unlikely that steroid will help in the situation. So, 4 to 6 weeks that we can stop. And it should be noted that in all causes of drug-induced AIN also, this might not work 100%. Okay. Now, we finished this whole section of drug-induced acute interstitial nephritis. Let's come to infection-induced acute interstitial nephritis. So, see, there are 2 ways in which infection-induced acute interstitial nephritis can occur. First is direct, like in acute pyelonephritis. What happens? There is infection can go and destroy the tubule, the antigen can get exposed and it can occur. Second is indirect, that is immunological mediated. That is antigen-antibody complex formed elsewhere can come deposit in the kidney and elicit an inflammatory response. So, it can happen directly or indirectly. Now treatment is treat the infection and corticosteroid is not indicated. Of course, we do not want to worsen the infection. This case of rifampicin induced AKI, though it was active tuberculosis, we had to give small dose of steroid because of the severity of the renal failure, and it really helped the patient. So it is really case to case based, but remember, as a rule, we are not supposed to give corticosteroids in any infection. Now this is a special infection that I want to deal with because it has a catchy name, that is hantavirus. It causes nephropathia epidemica. So nephropathia epidemica itself can come as an MCQ. Nephropathia epidemica is caused by hantavirus. It is also called as hemorrhagic fever with renal syndrome or epidemic hemorrhagic fever. Generally, the reservoir is rodent. The mode of infection is airborne like our COVID, and symptoms are extrarenal or renal. Okay, so extrarenal is, it's a hemorrhagic fever. So like dengue, there will be bleeding, fever and all that. Renal manifestations is generally proteinuria and hematuria. Like I told, it's a hemorrhagic fever. So there is always going to be blood in the urine and also along with the proteinuria, which can be nephrotic range. So the important point to remember is it is called nephropathia epidemica. Now renal biopsy, here you see this colorful renal biopsy in which, see, I generally told that if you remember in the previous picture here you are seeing only lymphocytes. See the color of the cells, it's only lymphocytes. Here in this picture, you're seeing a lot of red dots. These red dots are what are the RBCs. So you can see that there is hemorrhage into the interstitial space. Okay, so there will be hemorrhage into the glomeruli also. It will cause hematuria. So there is interstitial inflammation, there is hemorrhage, and there is vascular congestion. Immunofluorescence will show granular immune deposits along the tubular basement membrane and within the glomeruli. Okay, so this is like we dealt with the pathogenesis of any acute interstitial nephritis, and complete recovery is a rule in this condition. This patient, if treated and recovers completely, renal recovery, despite presentation of the kidney like this. Now we dealt with drugs, we dealt with infection. Let us deal with few systemic diseases that can present with acute interstitial nephritis. First is sarcoidosis. Okay, sarcoidosis generally can cause AKI by three things. First is hypercalcemia and hypercalciuria can occur. Okay, so this is number one. Number two, in the chapter of chronic interstitial nephritis, I will be telling how hypercalcemia or hypercalciuria can cause kidney disease. But just know that there is vasoconstriction of the afferent renal arteriole. It is a hemodynamically mediated situation in which AKI can occur. Third is granulomatous AIN. We also saw previously that this is one of the causes of granulomas in AIN along with Sjogren's and Wegener's. So hypercalcemia, hypercalciuria and granulomatous AIN are the causes of AKI in sarcoidosis. Presentation is they present with AKI, sterile pyuria and mild proteinuria. This is like any other interstitial disease. 90% of these patients have extrarenal symptoms, like of course chest involvement will be there. That could be one of the major manifestations of sarcoidosis. The important thing to know is this condition can relapse. Granulomatous acute interstitial nephritis can relapse if the steroids are not continued for a long time. So steroids have to be continued at least for a year. And most patients do not recover completely. Unlike in hantavirus disease where we saw complete recovery, here most patients do not recover completely. Okay. In Sjogren's syndrome, AIN is very rare. Acute interstitial nephritis are not commonly seen. Okay, what is commonly seen is chronic tubular dysfunction. Chronic tubular dysfunction is the most common manifestation of Sjogren's syndrome. Next is, it is responsive to treatment with steroids. In SLE also, along with glomerular involvement, 2/3 of the patient also have interstitial involvement. Okay, it is very rare that glomeruli is not involved but interstitial is involved. It's very rare. It's possible, but it's seen in around less than 5 to 10% of patients. Next is there is granular immune deposits along the tubular basement membrane like any other condition. It responds to high dose steroid and it is rare with minimal glomerular involvement. Like I told you, just interstitial involvement with minimal glomerular involvement is rare. IgG4 disease. I'll be dealing this disease in detail in the chapter of chronic interstitial diseases. But in IgG4 disease, what you have to remember is the most common kidney involvement is acute interstitial nephritis. IgG4 disease can present with multi-system involvement. So, acute interstitial disease is the most common kidney involvement that is seen. So, when we biopsy, we see IgG4 rich plasma cells in the interstitium and there can be immune deposits along the tubular basement membrane. Remember the pathogenesis page where we saw that lymphocytes are going and activating the lymphocytes and plasma cells. So, these are all going to be IgG4 rich. There in any other condition it can be any other IgG, here it is IgG4. Okay. So, it is associated with membranous nephropathy and renal inflammatory mass and it shows rapid response to steroid. Now, if you are not understanding much of this here, not to worry, we will be dealing with this in detail in the chapter of chronic interstitial nephritis. Now, Teneux syndrome. What is Teneux syndrome? Tubulo interstitial nephritis and uveitis. Okay, so this is Teneux. So this Teneux syndrome is, this is also an MCQ, but will not be very commonly asked, but it is an MCQ. We have to know the characteristic. It is generally seen in pubertal age group girls and the symptoms are initially like we told, uveitis can be there and nephritis can be there. So, there will be ocular pain and visual impairment initially and pseudoviral manifestations like fever, myalgia, arthralgia, all that can be there. AKI is, whatever is seen is generally mild to severe AKI and biopsy shows interstitial inflammation without granuloma and treatment is generally steroids. Okay, so remember that it is in the pubertal age group girls and initially there can be ocular pain, that is uveitis, and there can be pseudoviral manifestation and AKI also can be there. Okay, now prognosis in children is excellent, that is even without giving steroid it is going to recover by itself, but in adults it is not that favorable, it is less favorable, hence steroids is a must. And we have to remember that this is a relapsing disease. So, next time uveitis can occur without involvement of the kidney. So, it is not a must that every time patient develops uveitis to give steroids. Because if only uveitis is there, patient can be given topical steroids. Okay. In renal transplant, acute interstitial nephritis in renal transplant, it is important to know what is the most common cause. It is acute rejection. Okay. When rejection occurs, like in the chapter of rejection I discussed, lot of inflammatory cells will come into the interstitium. So, acute rejection is the most common cause of acute interstitial nephritis in renal transplant. Apart from it, BKV nephropathy can be there and drugs. These three are the causes. Okay. So, BKV nephropathy also we infections in transplant. BKV once it comes, it accumulates in the tubule only, it will cause tubulointerstitial nephritis and also drugs. So, the high yield points in this chapter is first is rifampicin induced AIN. You have to remember that it comes after episodic administration or intermittent administration. Okay, and it can also have extra renal features like there can be hepatitis, there can be hemolysis and also patient can have thrombocytopenia. So, that is about rifampicin induced AIN. Most important point is it comes on re-exposure or intermittent administration. Next is NSAID induced nephropathy. Those four important NSAID induced nephropathies you have to remember. One is hemodynamically mediated AKI. Second is membranous nephropathy. Third is papillary necrosis. Fourth is AIN. So, these are the four major, this can be an MCQ. Okay, so these are the major manifestations of NSAID induced nephropathies. Thank you, friends. you.